So thank you all, and thank you, Dr. Amit. So there are two topics that I was supposed to cover. One is the co-infection with HIV and hepatitis B and C, and the other topic was tuberculosis with hepatitis B and C. So I've tried to merge both of them, and I'll try to finish it in one presentation itself. So when we talk about these viruses and why do we need to know? Well, first of all, we all know we have been discussing, I am sure from the last 2 days, they must have discussed about the common mode of transmissions and then the commonality in the immune response. Now that you have to remember, very important thing about this is that the type 4 immune response is the one which is going to be the immune response, which will play a key role both in Hep B, Hep C, HIV, and as well as in tuberculosis. And this actually makes a huge difference. But that we'll see how it does and how it is going to change the disease presentations, disease response, and treatment response in all this group. Equally, you also have to see that the immune response, both for HIV and Hep B, they interact with each other and they change the disease outcomes also. Then finally, you also have a drug-to-drug interactions, which has to be kept in mind when you're treating these patients when they are together. And the drug-induced adverse reactions also has to be seen because that they actually change the outcomes in these patients. For example, in a very simple way, if in TB patients, if you have Hep B and then the patient is treated with anti-tubercle drugs, it's very simple. So the liver uh, reactions tend to be much higher as compared to the normal population. So these things have to be kept in mind when we are dealing with these combinations. Now, if we look at the percentage of both, let's say Hep C and Hep D, I'll give you one this simple incident which you all must have remembered. This happened 4 to 5 years back when there was this huge news item that now a district where a quack led to the spread of HIV. Nearly 32 patients of HIV came positive, and they started searching for that. This was very very much covered by media and all. But when the agencies, when these experts went into that area and they started searching for it, one thing that came out is the patients of HIV, nearly 90% of them had Hep C, but more importantly, the whole area had nearly 80% prevalence of in those villages of Hep C. So you can see that the common mode of transmission leads to the presence of both the infections together. Now, why was that? One of the important reasons that we know as of now is that the prevalence of IDUs and quacks in those areas is very high. IDU in Kanpur Dehat, in western side, in certain pockets, you have a lot of IDUs, and this IDU population leads to the presence of both the viruses together. And this is something which has shown that the HIV Hep C epidemic is actually going on together. We know that all the three are bloodborne infections, but what you have to remember is the needle stick transmission of the three viruses varies a lot. If you look at, this is from NACO and this is from the CDC, which NACO keeps on teaching every time since last 15-20 years. Look at the difference in the transmission rates between the three viruses. If you have a needle stick injury with HIV, the transmission per prick is just 0.3%, whereas with HCV it is 2%, and with Hep B it goes up to nearly 50%. And that what you will see even in the general population. If your HCV rates are very high, you can easily suspect that the patients most probably out there are actually, you have a very high prevalence of IDUs or quacks. Now, what happens with HIV and Hep C? They had a study where it shows there are certain things which, as we discussed, makes a huge difference. The sexual transmission in HCV is not that strong, and neither is the mother to child transmission as you would see in other viruses. But what you'll also see that is, if you have a patient of HIV and if the patient is an IDU, and if suddenly you start seeing an increase in ALT levels, then immediately you should start suspecting that most probably this patient has an exposure of HCV. Now, HCV, what happens if you have a needle stick in HCV? How do you detect whether the patient has become positive? If you have a healthcare worker and the person has a needle stick injury from HCV patient, how do you detect? What is the first test that you would like to do in this group of patients? I mean, the same thing goes for IDUs also. If you have one needle stick prick from an HCV patient, how do you decide whether this patient has now developed infection? Because you do not have a post-exposure prophylaxis, you do not have vaccination. How do you decide which test to be done first and when? Any? ELISA would give you the test result in 6 months. So HCV RNA will give you from 3 to 4 months. So the difference is that you have to remember, I think this Dr. Amit and his team would explain better. So you never do that, because actually what happens is the HCV virus is a hypertrophic. It actually starts multiplying inside the liver, and if you do an RNA load also, you will never get it positive till at least it starts spilling over into the blood. And this doesn't happen nearly for up to 2 to 3 months. अगर आपने कभी HCV RNA का टेस्ट कराया हो किसी भी लैब से, the lab, any good lab would write underneath, अगर ये नेगेटिव भी है so please repeat it after 1 month, because there is always this chance sometimes the HCV RNA doesn't come into the blood. So the test which has been suggested is just do the baseline ALTs and ASTs and repeat it after 6 weeks to 8 weeks. अगर किसी को HCV exposure हुआ है, the first thing that will happen is the ALTs and ASTs, especially ALT, will start rising. If you have a 3-time rise in that person from the baseline, that means this person has had an acute inflammation from the HCV. That's all you will see. And then you should follow him up, do the HCV RNAs, and if required, the antibodies at 6 months. That's how you will come to know whether this patient actually became positive or not. You should not just start off with the RNA. So these are certain things you have to even remember in HIV also. That's a matter which can be discussed separately. So in IDUs also, because we have IDUs who keep on coming, and IDUs will keep on getting repeatedly exposed. It's not like that once you treat, he is going to stop. वहां पर अगर HIV के क्लिनिक में आ रहा है, वो अगर हम कंटिन्यूअसली हम लोग मॉनिटर करते हैं, तो the thing that we keep on watching is the ALT. The moment the ALT starts jumping, that you know that this patient suddenly has had an exposure with HCV. This is what you have to remember when you are actually following up these sort of patients. There is low efficiency of sexual transmission, and the HCV progression, disease progression is similar both with HIV and HCV. That doesn't change much in the patients. The other thing that you have to remember is that a mother-to-child transmission for HCV is usually 4 to 8%. But when you have a co-infection with HIV, the transmission rate goes up to nearly 10 or up to even 25%. This changes the whole milieu. ज्यादातर अगर आप किसी उससे पूछोगे तो मदर टू चाइल्ड ट्रांसमिशन के लिए बहुत ज्यादा वैल्यू नहीं दिया जाता है हेपसी में. इट इज मोर इंपॉर्टेंट फॉर हेप बी एंड HIV. But when you have a co-infection, the rate of transmission doubles or nearly triples when you have the HIV with HCV. This is something that you have to always remember. There is always increased progression of the HCV disease if you have it with HIV, and that leads to further risk of development of hepatocellular carcinomas pretty early. And the death rates also tend to be much higher if you have combined disease. The good thing is, majority of the drugs which are using, you tend to actually work well with HIV drugs also, and the outcomes tend to be same, and the drug dosage and the durations do not usually change, except that you have to keep a watch on the drug-to-drug interactions. That is why it becomes simple for HCV patients to get treated even if they have HIV along with it. So if you look at this, these are the drugs where you need to do modifications. One good thing is now we are not using many of the drugs which you see in the HIV line. What we are using is tenofovir, lamivudine, and dolutegravir. And dolutegravir tends to not have that much of drug-to-drug interactions with the HCV drugs which you are using as of now in the program. So you do not have to make any major modifications, and the outcomes tend to be same. The duration tends to be same, which does not actually need to be changed. So if I can go ahead, I'll go to the HBV now. HIV and HBV co-infections are a bit more common. Percentage-wise, even in our own population, in this city, once a study was done, it is around 7 to 8% when you tend to have with both HIV and HBV co-infections. This can go up in many other places also. The other important thing is when you test, you tend to test with anti-HBsAg, and they also tend to have reactivation. As the previous speaker said, that in immunocompromised, you tend to have reactivation. The irony here is in HIV, the moment the immune immunity starts improving, then you'll start having reactivation. That is what you have to remember. The irony of HIV is the moment you start treating for the 6-8 months, you will actually most well lead to deterioration of the patient. And you have to be ready with that. You should be ready and you should be very watchful for that. Now, globally, as I said, even in North America, that 10% of people have a co-infection, and the transmission routes vary from place to place. It could be perinatal, it could be early childhood exposures, which are still very common even in India. And the chronicity of the HBV is much more common if it actually occurs in a much younger age group. This is the prevalence of HBV and as well as HIV. If you look at it, the HBV, if by the percentage wise, India actually doesn't come into high prevalence, but if you look at the volume wise, we are still number 3. We have a pretty huge volume wise. We have a high. What happens in PL-HIV is there are certain things which change. Here, many of the times you will find an anti-HBC, isolated anti-HBC positivity, and you may not get the HBsAg positivity. The importance of this still is not pretty clear, but most commonly it is a sign of that the patient might have had an infection and might have improved, or the patient might still be harboring as reserves in the liver. So this actually makes a huge difference in the sense that once you start the treatment, suddenly the immunity might start getting activated and the liver might start getting decompensated and you might have a reactivation. The clinical significance has not been clearly stated, but it is usually suggested of chronic or a resolved HBV infection. This is a graph which I think this is a flowchart which you must have read out. This is what you use for treatment in chronic hepatitis B. And this is what you suggest for treatment. But in HIV, what happens is in HIV, this immune tolerant phase, most of the patients will be there in the immune tolerant phase. And the moment you start ART, the antiretroviral treatment, what will happen? The immunity, which was low, will now suddenly go up. Usko iris hoga, immune reconstitution hoga. The patient who was actually tolerating it very beautifully, that the virus was there, hepatitis B virus was there, and the body was tolerating pretty beautifully. The moment you start ART, the patient will now suddenly shift from the immune tolerant phase and go into the immune active phase. And here you will have to actually start thinking about treatment. And another important thing is, I think my they have put me there. That's not me. So is that even after treating, they tend to develop the DNA and intrahepatic virus tends to be much more. Now, what does this make a difference? अब आप जब treat करते हो tenofovir से in hepatitis B, you'd say 1 year or 1.5 years treatment. Isn't that's what you do usually? But in HIV, that doesn't actually hold true. You might even treat for 2.5 years and still the patient may be showing the virus positive. But that doesn't mean that the virus is resistant. It is just that the virus goes on sitting in the cell and it will keep on leaking out little bit. And this DNA will be always positive. You will tend to get this DNA whenever they do the test. And this is very commonly seen. And this is something which is very important. And this has been seen in several studies also. So this has been seen in several studies also. What happens is you have to be very careful while monitoring. You have to look at the clinical picture, you have to look at the virus, you have to see the virus load, and just not stick a 1.5 साल हो गया अभी मेरा virus positivity अभी भी आ रहा है तो हम सीधा tenofovir से entecavir खुद जाएं किसी और पे खुद जाएं, ऐसा नहीं. The patient might still be actually be the virus would be still be sensitive to tenofovir, but it's just that it's not going to get cleared off. Studies have shown that even after nearly 32 months, you might have them and still be sensitive, but you can still continue with your tenofovir and not jump to entecavir. So you have higher load, lower level of resolved infection, spontaneous seroconversion is much lower, and viral clearance in blood takes more time than an immunocompetent patient. I'll just give you a small case before I finish the hepatitis B. So this is a recent case, not even a one. Recently, just a week back, one of my ART centers, they called me. So a 42-year male was referred to ART center with positive both HIV and Hep B, and currently in WHO stage 2. I'm pretty sure you must be knowing the new HIV guidelines. We really do not now look for CD4 counts or anything. We don't even look for the WHO staging. We start off with the ART treatment. That is as per the present protocol. And as per present protocol, CD4 is not even done in most places. They usually do not do it unless the clinician, the nodal officer specifically asks. Otherwise, they are actually monitored with the virological picture. You do HIV HIV RNA load. Now, this patient has been sent, and the patient has a bilirubin of 12 and the WHO stage of 12 with deranged ALT and AST. So, what should be done now? What should be the call? So what do we do? Start ART, wait for ART, or start tenofovir, wait for tenofovir, give him a time, ask him to come back, look at his viral loads. And I'm pretty sure the ART clinic is going to send him back to viral hepatitis clinic. Nobody does anything. हर आदमी refer करता है एक दूसरे को. So what should be the next line of course for this patient? So technically, I'll just tell you what they did. They referred him back. They said we'll wait for 7 days. Why? Because the first line treatment is tenofovir, lamivudine, and dolutegravir. And dolutegravir usually, though in a normal patient it's not hepatotoxic, but where the liver is already not working properly, there you will have a tendency that it will actually derange the liver enzymes, and the bilirubin will further get deranged, and the patient might actually land up into the disease might progress further. So they sent him back, and then this patient again came back after 7 days. They called him back after 7 days with LFT. Well, the good thing is the LFT came down to 9, and the viral hepatitis clinic started tenofovir, and they referred him back to the ART center. Now, what does the ART center do? What does the ART center do? What did the viral hepatitis clinic do? That's as simple. What do you think they are correct in doing that? So पहला चीज ये है कि भाई कि जो टेनोफोविर है ना HIV का भी दवाई है. अगर आप ऐसे चालू करोगे तो फिर तो एक को तो बचाओगे, दूसरे से उड़ा दोगे. The viruses will become very resistant immediately. Tenofovir is one of the main backbone of HIV treatment. And if a simple data is that if you give single drug in HIV, in a month's time it will start becoming resistant. If you give two drugs like T and L, then it will stay for 9 months to 15 months. And if you use 3 drugs, that is the reason for actually using the 3-drug combination, then usually you see a time period you can actually maintain for 10 years. That's what the data shows. Now, of course, we have got newer drugs which are supposed to be very good, where you can give one shot and wait for the whole year with the injections and all that are coming in. But the present line, if you give single drug, then the HIV virus will become resistant. So that is the first call to the viral hepatitis clinic. Do not start off like that. Otherwise, you'll end up actually losing this drug. Now, the other thing is the other way around. Now, if you look at it from the ART center wise, one, do they start the dolutegravir or not? Or do we start the TL? So the option was you could have started with tenofovir with lamivudine. अब lamivudine को तो viral hepatitis वाले जितने भी हमारे hepatologists हैं, they think that is the most useless drug without not making anything. But the point of thing is, the moment you have lamivudine in any regimen, the lamivudine when का resistance जो है ना 15 दिन के अंदर हर बीमारी के लिए हो जाता है. But फर्क ये है, the virus that is formed from the wild virus, once it develops its resistance, it's a weak virus. It does not enter into cells so fast. So that is why if you look at the antiretroviral treatment, कहीं भी lamivudine is always the backbone of the regimen. इसलिए नहीं कि दवाई अच्छी है, इसलिए क्योंकि जब वो वायरस जो बदलता है वो फिर किसी और को उतनी जल्दी इफेक्ट नहीं कर पाता है. Option was you could have started with tenofovir and lamivudine, and maybe call after 1 month and then take a call. अब problem number 3 ये है कि the government of India comes with fixed dose combinations. It doesn't come with वो उसको कहता है एक पिल दो भैया भेज दो, उसके बाद आता नहीं है. तो tenofovir lamivudine के combination नहीं आता. It comes as TLD. So you have to give them separately. So looking at that, the ART center then finally took this call. We will give TLD, monitor 7 days, and then come back. But then is that all that they have to do? Should they remember anything else? And this is a case. This is very commonly this keeps happening. This is something which happened just 10 days back. The thing that you have to remember is, अगर आप कर रहे हो, Government of India के plan में जो हट गया, but you should do a CD4 count. The moment you put the patient on TLD, क्योंकि वो tenofovir के साथ है, so the immune reconstitution will occur. Now this patient might come after 3 to 4 weeks and you might suddenly start deteriorating. अब उस समय तो आपको पता नहीं चलेगा कि डॉलिटोग्राविर के कारण हुआ, हेपेटाइटिस बी के कारण हुआ, या CD या इम्यून रिकॉन्स्टिट्यूशन के कारण हुआ. So before doing that, you should always do a CD4 and repeat it after 1 month. If the patient was improving, nothing better than that. But if the patient starts deteriorating, you should be ready to make this differential diagnosis कि ये immune reconstitution से था, कि वायरस पर से था, या फिर वो दवाई के कारण था. वो आपको सिर्फ CD4 काउंट के राइज से पता चलेगा. If it is rising and the patient is deteriorating, that means iris. So in such scenario, you'll have to stop all drugs because it can be fatal, and then you might even have to give steroids. That is something you'll have to remember. So they should do a CD4 baseline, put the patient TLD, monitor patient carefully, repeat the CD4s after 1 month, and maybe keep a watch on that. You might have certain other options also. This is just one way of treating, but this is what you have to remember whenever you're treating Hep B patients like this. So this is what you have to think about. So we have discussed already these, and we have discussed in this case the immune reconstitution, which is very important, which has to be kept in mind. So severe injury can occur if you do not keep in mind the immune reconstitution and the drug-to-drug interactions and drug adverse reactions in these sort of patients. So finally, coming to one more important thing, that is the mother-to-child transmission, which is something which you have to remember. Whenever we are treating for a mother, you should remember that all the 3 drugs should be started immediately, and the regimen should contain tenofovir. You should not actually remove it. And the rest, I think, is similar to what you would do in any universal immunization program, which you follow for the mother-to-child transmission prevention in hepatitis B. Finally, as far as coming to the prophylaxis and Hep B, as the previous doctor emphasized, if the CD4 is above 350, then you have to treat them as you would treat any normal person. उसमें आपको कुछ और नहीं करना है, वो एक normal healthy human being के तरह जैसे vaccination करते हैं वैसे ही करना है. But where it is less than 350, then you might go for double doses. You might even go for the कुछ लोगों ने जो chronic kidney disease के regimen है वो भी use किया है. But as to date, there is nothing like specified which has been laid out. So you can actually use anything. In CDC actually asks for 016 Hep A Hep B का combination vaccine लगाते हैं सारे HIV patients को. That's in US. But in India we do not have specific separate guidelines for them. And this is for the non-responders. This is what they suggest. So any other question here, or I'll finish off with the final HCV and TB. Okay. So vaccine response, again, as I said, depends on a lot of things. At which stage the patient is coming, at which CD4 the patient is coming, WHO stage क्या है, and plus उसमें underlying क्या आ रहे हैं. So many of these patients, as I said, in anti-HBC बहुत सारे में positive मिल जाते हैं. If the anti-HBC is already positive, that means there is already a chance that he has been exposed or he is having it. उनमें the funny thing is, it has been suggested that even these people should be vaccinated if the HBs AG is not positive. That's one. But उनमें response बहुत अच्छा नहीं आता. But if for others, the response is very good. Some people say कि जब उसका 350 के ऊपर आ जाता CD4, then you should again look at the patient's antibody levels and then take a call. HIV में एक चीज important चीज that you have to remember is HIV में B cell immunity is never low. HIV में हमेशा जो T cell immunity है वो गया हुआ है. So आपके anti-HBs AG तो बन जाएगा. आप जो HIV में टेस्ट क्या कर रहे हो, आप एंटीबॉडीज टेस्ट कर रहे हो HIV पेशेंट के लिए, वो कितना भी नीचे हो पॉजिटिव आता है, क्योंकि B cell immunity हमेशा उसका एक्टिव रहता है. That is why the immune reconstitution is also so bad in HIV as compared to others. HIV में आपको autoimmune diseases भी बढ़ जाते हैं, because the T cell immunity is the one which is suppressed. B cell is still very active, and it is hyper-regulated actually. It's not active, it is hyper-regulated. So the antibodies do form, but what do you have to follow them up afterwards? That is why till date they have not had any specific separate. Maybe you can have a look at it afterwards. So final 4-5 slides just on TB. I know there isn't much data about it. The same thing happens. अब आपको यही वाली चीज है T4 जो type 4 hypersensitivity reaction जो इन तीनों viruses में होता है, that is also the one which is playing the active role in TB. So what happens is there is lot of changes once these viruses come in. Any virus actually modifies the type 4 immunity, and that leads to deterioration in disease. By and large, what has been seen is if you have occurrence of both TB and Hep B, the chance is that there will be poor outcomes for response for both the treatment. Both TB का treatment भी बहुत अच्छे से clear नहीं होता, and as well as the Hep B treatment also does not respond in the same way, and that leads to further deterioration. That could be because of the modifications in the cellular immunity. Equally, what you have to remember is the severity of infection when I say is nearly, it increases by 80%, and the success of anti-tuberculosis treatment in patients with hepatitis B comes down by nearly 20%. Many of the people might need extended treatment of ATT. The other important thing is the poor adherence of tuberculosis drugs. These patients tend to develop hepatitis very commonly, due to which the patients tend to have dropout rates. Secondly, there is poor bioavailability of the drug. And thirdly, the drug-induced liver injury is much more common. These three things actually aggravate the already which is being modified by the immune system. The risk of liver injury in co-infections is nearly, I mean, if you look at it, it is pretty increased, and it is higher in TB, and that leads to more patients with positive have likely do tend to have liver injuries. One important thing that you have to remember is TB is exactly like HIV. Over the period of time, आप जितना आप TB को treat करते हो उतना आपको पता चलता है वो HIV से बहुत कुछ match करता है. If you treat a pulmonary tuberculosis, I'm pretty sure many of the doctors out here must have treated pulmonary tuberculosis anytime. What you would have seen is उसमें drug-induced hepatitis बहुत rarely होता है. If you ask a pulmonologist क्या drug-induced hepatitis होता है with ATT drugs, they'll say वो बहुत कम होता है, 3%, 4%, 5% के आसपास बताते हैं. But once you enter into the extrapulmonary sites, it is something like exactly the posse immune status. And the moment you start ATT, after 2 weeks, they tend to have a severe immune reconstitution. And this immune reconstitution, specifically when it is present with the Hep B, just like HIV, it tends to aggravate the whole disease. अगर आप किसी न्यूरोसर्जन से पूछोगे, the tuberculous, जैसे tuberculomas होते हैं या फिर you have tuberculous meningitis, in tuberculomas, they usually cover it with steroids for nearly 3 months. They don't stop it early. And similarly, in patients like bone TB, they tend to give steroids for a long time. That is just to stop this immune reconstitution. So you have to remember that HIV and Hep B, Hep C, or TB and Hep B, Hep C, they will have a very similar sort of outcome, because all the four are working in the same immune system by which they're actually interacting with each other. I think that's what it is. Thank you.